COVID-19 Clinical Readiness and Patient Care Teleeducation session for April 15th, 2021. My name is Sean D'Andrea. I'm the Chief Clinical Consultant for Emergency Medicine for the IHS. And today we're going to have a discussion following a presentation by Dr. Marilyn Glassberg regarding the long-term effects of COVID-19, specifically post-COVID-19 pulmonary care. We hope to allow time for questions and answers at the end, though we expect this will be a full presentation. So please don't forget to share your questions in the chat feature throughout the session, and we'll work to answer as many of those in real time as possible. There will be CME and CE credit available following the completion of a post-session survey, which will be pasted into the chat feature of Zoom towards the end of today's presentation. As always, this session is recorded and your attendance serves as consent to be recorded. The recording will be made available on the Project Echo website following today's presentation. For a copy of Dr. Glassberg's slides, please see the initial invitation announcement from the Project Echo team. And again, CME is available following the completion of the post-session evaluation. And without any delay, it's my pleasure to introduce our speaker today, Dr. Marilyn Glassberg. Dr. Glassberg is the inaugural Division Chief of Pulmonary Medicine, Critical Care, and Sleep Medicine, and the Vice Chair for Diversity and Inclusion, as well as the Senior Director of Clinical Research for Strategy and Growth in the Department of Internal Medicine at the University of Arizona College of Medicine, Phoenix, and Banner University Medical Center. In addition, Dr. Glassberg serves as Physician Executive Director for the Banner Health University Lung Institute. And I'm very pleased at this point to turn the conversation for long-term pulmonary care over to Dr. Glassberg. Thank you.
Hey, Marilyn, you're still muted.
Can you hear me now? Yes.
Loud and clear.
Good. So I was saying last time we focused on the heart. This time we're going to focus on the lung. I'm going to try to provide some perspective of all that we've learned. When I spoke to this group before with Michelle, you know, we were just at the really beginning of how to take care of these patients and triage them. I have to say we've come a long way. Not as far as I wish we were. I wish we knew who was at risk for developing this long-term lung disease that I'm going to talk about, but I think we understand sort of the spectrum. So the objectives in the next 40 to 45 minutes are to review the pulmonary presentations of COVID-19 disease. I'll go through a lot of imaging and pathology samples from over 150 lungs that we've looked at that developed pulmonary disease. I'll spend some time with the vascular complications we're all very well aware of, as well as some novel imaging applications that we've helped to develop. And I'll then spend the last part of the talk talking about long-term COVID-19 pulmonary complications and give you patient examples. And I hope then we'll have some discussion about your own experience with your patients. Some bad statistics for Arizona, where I now live, is that it has one of the highest per capita rates of COVID-19. Its SVI exceeded 0.9. It was ranked in the top 20% in all Arizona counties for PVI, which are these pandemic vulnerability index. Of every 100,000 Arizona residents, 11,000 of them had COVID-19 and 247 had died. This was as of the end of March when we put this grant in. Really hit the Hispanic and the Native American populations that are so important to us pretty strongly. And due to COVID-19, we really had a crunch with the ICU hospital beds. And what we're seeing now is that a lot of those patients that ended up in the ICU are ending up in the long-term clinic. And this has also been shown in Wuhan, that patients that had the more severe respiratory disease do seem to be the most at risk for the long-term complications. So let's just look at a few facts about what we know about COVID-19 and lung disease. So as of February 2021, almost 30 million Americans were infected by the virus. About 2% of patients with COVID-19 have concomitant pulmonary disease, which is associated with worse outcomes. I've included a few references for the papers that I think are worth taking a look at. And Yang's paper I particularly like. Early studies indicate that 1 in 10 people with COVID-19 may develop post-pulmonary COVID of unclear duration. So we don't really know when they get it or how long they're going to get it, but we do understand that certainly a group of them are at higher risk. Who are they? They tend to be patients that are older. I'll show you some data with the vascular complications in that group, as well as those that have moderate to severe asthma and any chronic lung disease. In a paper by Huang that was looking at the over 1,700 patients from June to September of 2020 in Wuhan, he and his group reported that 56% of COVID-19 survivors who developed ARDS had more severe impaired pulmonary diffusion capacities and abnormal chest imaging. And we'll take a look at some of that data. 10% of the patients have persistent symptoms for 1 month, with 1.5 to 2% having sustained symptoms at 3 months. And unfortunately, long COVID seems to be more common in women, about twice as much, with a median age of 45. Where in the spectrum of the disease do they develop COVID pulmonary disease? Well, it's really anywhere. This is from a paper that actually talked about the management of mild and moderate illness that many of you are probably familiar with, that was in the New England Journal, sort of presented as a case series like at MGH. And we know that they can get this COVID lung disease even if they're asymptomatic, that a lot of the patients that have had these chest x-rays that show the interstitial, sort of the ground glass patterns when they get the scans, don't necessarily have to be severely hypoxemic or have any other symptomatology with it. So when we look at sort of the spectrum of where we're going, we know it can hit them at any point in this graph, right? Between the table, between asymptomatic, mild, moderate, or severe. As I've mentioned a couple of times now, though, we know the severe are going to be at more risk. What's this mechanism? So the mechanism is complicated, right? There's a whole host of mediators, drugs that were tried to block, like IL-6, interferon gamma, natural killer cells, GM-CSF. It was all tried. None of them were successful. And it's because it's very complicated, and the immune system, which is demonstrated here with these memory CD4 cells and the local B cell follicles, really seem to set up shop that tends to be long-term. I will show you films where the ground glass opacities, really signaling inflammation, can hang around for a very long time. It means that there's an ongoing process. Is that process just inflammatory? Is that process also vascular? We're not sure. So here's I want to get you guys so I can see your pictures. This is a very interesting patient that went on to develop severe disease. So you see on the left-hand side, the sort of what we've known now as standard COVID-19 ground glass opacities. You see the white, almost like the butterfly pattern. And then what you see over on the right side is really tremendous interstitial disease with traction bronchiectasis. And I'll go through films very carefully with you to show you this. And what's interesting, though, is that they don't develop honeycomb end-stage lung disease. So it looks bad. The good news is that a lot of them get better, even when they look like this gentleman here. What does the pathology look like? So we've looked at over 150 lungs now with Tom Beach, who received an NIH grant to actually do autopsy studies with us and with Stanford. And we can see that they develop really a lot of destruction of pneumocytes, particularly type 2 pneumocytes. Hyaline membranes form, there is pulmonary edema, there is congestion, but as we noted, it doesn't necessarily have the trajectory of chronic lung disease, but you can see the burden of disease just in this section. And then, of course, those that smoke, as shown here with the anthracotic pigment, seem to be at somewhat increased risk. The story isn't, and the verdict is not out about smoking yet, whether there's been papers that suggest that they actually may be protective by having smoked. I don't think so, certainly not in our group. The pattern of diffuse alveolar damage, though, is not specific to COVID-19, and we shouldn't think of it that way. We should think of this as an ARDS pattern. If you remember early on, there were a lot of papers about this is a different kind of ARDS. No, it's actually the same thing that Warren Zapal described in the 70s and 80s in ARDS patients when he looked at a whole series of them at MGH, which had tremendous pulmonary vasculopathy. And so this is a similar group, right? However, the patients that present with DAD, they also have this bronchial dilatation, somewhat more organized pattern in the background. And the thought that a lot of us have is that this is developing before they actually present with the disease, that they don't have the clinical manifestations, but their lungs are hit very early on. The key findings are that they have this lobular airspace disease, they have interlobular septal thickening, which can't happen overnight, and then three distinct lung attenuations in multiple lobes. You can see nothing. You can see a lot of the haziness that I described as the ground glass. But most importantly, you can see consolidation, like in a pneumonia. So that's probably the worst of it, right? Is that and I think they've been a problem for all of us taking care of them, is do we treat them with broad spectrum antibiotics as well? Do they have a concomitant pneumonia? We've certainly seen a large group with concomitant cocci. So maybe there is some other susceptibility to this that we don't know yet, but the end pattern that they end up with is diffuse alveolar damage, not chronic fibrosis. It's not like a Hammond-Rich, where you get acute interstitial pneumonia and rapid development of fibrosis. That's not this, but this is what it is. And I've tried to diagram this, that it's this very thick ground glass opacities. They look very fluffy. And then you see them start to consolidate, right? With many areas of the lungs being involved. They do develop traction bronchiectasis. You can see these tracks here that really describe how dense the inflammatory process is in these lungs. There are two key findings you should remember. One is the organizing pneumonia pattern shown here. So this is from my colleague, Mike Morris at Banner, which we've been getting groups of cases together. And what he always points out very characteristically is the subpleural clearing. This is very similar to what we also see in nonspecific interstitial pneumonia. A pneumonia that's not really a pneumonia, we see it in autoimmune lung disease, where it's a very homogeneous, diffuse inflammatory process. This looks very similar. It's called organizing pneumonia because when you look at it, it's densely inflammatory. The second pattern you'll remember is nodular, right? Over 50% of the lesions that the patients have, they almost look like they have a halo inside of them, like they're lucent, they're hyperlucent. But what you see is they're sort of scattered. There's minimal features to the organization, and they can be located peribronchially or peripheral. They're fairly large nodules, though, as you see in the CT scan and also in the coronal. What about pneumomediastinum? For those of us that have taken care of lots of these patients, this is one of the hardest things to deal with the COVID-19 population, because they get pneumomediastinum with or without mechanical ventilation, neither non-invasive nor invasive. They seem to be predisposed. What's known about the pneumomediastinum is that when patients were looked at where the plateau pressure was constantly less than 25 centimeters of water pressure, for patients who had mechanical ventilation, suggested that when they developed their pneumomediastinum, it was not related to barotrauma or traumatic tracheal intubation. So we've all seen this with asthmatics, right, where they develop a pneumomediastinum. This isn't the scenario. We don't understand what's happening. There are cases of pneumomediastinum, of course, with patients on prolonged mechanical ventilation, even in those where they've confirmed that a lung protective invasive ventilation strategy was used. Pneumomediastinum is seen in a lot of other diseases, right, where we know that there are problems in the architecture of the lung, in acute exacerbations of idiopathic pulmonary fibrosis, pleural parenchymal fibroelastosis, or melanoma differentiated associated protein 5 related interstitial lung disease, or some of the many, right, where we see this. Of course, we also see it in eosinophilic granuloma and others, but the mechanism is different. It's thought that the pneumomediastinum in COVID-19 is due to the rapid course of inflammation and lung architectural change that's causing this problem. But truthfully, it remains unclear why so many of them develop pneumomediastinum. I show you a diagram from a nice paper in ERJ Open Research. Then the black arrow showing you the air, and then the white arrow showing you what I mentioned in the other sections, the traction bronchiectasis, really the dense, as you see here, really dense whiteness to the CAT scan, to the really dense inflammatory infiltrate that's going on. What are other kinds of patients that get and what happens to them? The autoimmune population has been looked at. I just show one case from Truong that was published in the Journal of Rheumatology, which is interesting because the baseline film is shown to you in A, where the patient has a little bit of interstitial changes, right, with some reticular findings, but then develops COVID a few months later with the striking findings that we've discussed. And then by July, the patient was treated with steroids as per the recovery protocol. The patient does go back to pretty much the baseline, although there seems to be in the right lung a little bit of more reticulation around the periphery. How much of that could be exacerbation of the underlying rheumatoid lung versus residual lung disease from COVID isn't known. And so a group of these patients are being followed with autoimmune disease to try to see if we can sort out if indeed this could be a reason for exacerbation of their underlying lung disease. As you know, we really don't understand which of these autoimmune patients or why they develop interstitial lung disease. So this has become very interesting as their lungs seem to get hit a little bit more. Yi et al. Published in March of last year a review looking at all of the papers that had been published at that time of CT manifestations of COVID-19. This is a cumbersome chart, but if you look across the top, right, and read across, we can see just how much has been reported. Ground glass consolidation, a mix of ground gas and consolidation, thickening, reticular, crazy paving, right? Much like a vascular disease, air bronchograms, thickening, bronchiectasis, pleural thickening, involving of the pleura, which is why I mentioned pleural pulmonary fibroelastosis as potentially this being a risk for that, only treatment for that being transplant. And as we know, we have had several patients now, more than one handful, go to lung transplant with post-COVID disease. About 2 to 6% of the patients will end up with residual lymphadenopathy, which is also noted in this chart. So going back to the Huang paper, he made some interesting observations in his 6-month group that I mentioned before of the over 1,700 patients that they followed. The quote from the paper was that those patients seemed to be troubled with fatigue, muscular weakness, sleep difficulties, anxiety, or depression. The ones that were more severely ill and had required mechanical ventilation ended up with impaired pulmonary diffusion capacity and abnormal chest imaging. And they pointed out that they should be the main target for long-term recovery. So in this chart that really looked at spirometry plus diffusion capacity and volume measurements, if you just look at DLCO in the top figure and go across, if we just look at patients, scale 3 is not requiring oxygen. A small percentage of them still ended up with diffusion impairments, those requiring supplement a little bit more. But then look at the group that required some form of high flow, non-invasive or invasive mechanical ventilation. Their diffusion was significantly reduced. So I think his observation is correct. We have seen the same thing, suggesting that there is probably some regional preference to where the disease is hitting. I showed you some with the lower lobes. And we know from the west zones that if we hit the lower zones, we're going to hit the perfusion more intensely. This may be what's being reflected, but is really what caused us to look very closely at the vascular compromise that these patients have. The bottom part of this figure just quantitated sort of what the CT findings were. So just before we got on, we were talking about how many patients might get pulmonary emboli and how many might get DVT. It looks somewhere in the literature between 10 and 13% of patients hospitalized with COVID-19, which is pretty high. But the diagnosis of it is not so easy because an elevated D dimer doesn't confirm the diagnosis in a patient, because we know now that the D dimer can result from the infection or other causes. It was looked at in the early trials with anticoagulation and found not to be of value, and certainly in the active trials. If possible, angiography or bilateral ultrasound should be performed to investigate for PE and DVT, especially for those patients that are profoundly hypoxemic. And early on, we talked about happy hypoxemics, right? They sit there and their SATs are in the 80s. And empiric use of full dose heparin or low molecular weight in this group of patients who do not have other indications for therapeutic anticoagulation outside of a trial is now discouraged. And I'll show you the release that came from the NIH when they closed the trial. Most importantly, though, in all of the autopsy findings to date is the problem of microthrombi. We see it in the kidneys, we see it in the lungs, we see it diffusely. And that's really a major concern as we start to talk about long-term disease. This was the announcement December 22, 2020, when the NIH active trial paused the enrollment, paused for a few reasons, as we all know, mostly really futility and also for side effects. But this stopped the sort of rampage of anticoagulation trials that were ongoing, often very empiric. As we know, in the management of COVID-19 patients, a lot of the time there wasn't necessarily evidence for what was being done because we didn't have time to get the trials done to be able to support what we were doing. So are there any clinical scenarios of suspected thrombosis in which empiric therapeutic anticoagulation would be considered? This is taken from the American College of Hematology website, and I think it summarizes, I'm going to tell you two scenarios. One is this one. Well, where should we continue anticoagulation? And you see there are no contraindications and there is a very high clinical suspicion, but no possibility of performing imaging studies. So I think number one is intubated patients who develop sudden clinical and laboratory findings that raise your suspicion for PE. I once had an attending who said, if you think of it, don't worry about ruling it out, get them anticoagulated. I think that still holds for this group. And certainly in the setting where, their radiography may be improving, but their oxygenation is not. Number two is patients with physical findings consistent with thrombosis, right? Superficial thrombophlebitis, peripheral ischemia or cyanosis, thrombosis in the dialysis filters. This was one we saw early on in the COVID-19 patients, was that they were clogging the dialysis tubing. There were large groups of end-stage renal disease patients coming in with COVID, right? They were clearly at risk in the dialysis centers, but you never saw clots like this, right? This was an early indicator for us that something was really amiss with this disease. And third, patients with respiratory failure, particularly when the D-dimer and or the fibrinogen levels are very high, in whom PE or microvascular thrombosis is highly suspected and other causes are not identified. So we would still use anticoagulation in this group. And then the second question they address very nicely on the website is, how long should we treat these patients? And nothing has changed in terms of how we manage them. It should be a minimum course of 3 months of the therapeutic regimen, as long as there are no side effects. The resolution can occur within a few days of effective anticoagulation. So negative results from delayed testing should not be interpreted as implying the PE or DVT was not previously present. Some of these are because I think the clots are very small as well. And so there may be improved resolution and no further shadowing once you anticoagulate them. At 3 months, therapeutic anticoagulation can stop, provided the patient has recovered from COVID-19 and has no ongoing risk factors, thrombosis, or other indications for anticoagulation. We have seen profound immobilization in these patients and weakness, bedriddenness, that clearly still puts these patients at risk. And I include the website here if you'd like to review their recommendations. So we've been focused on the vascular piece of this, and we collaborated with a group out of Belgium, Fluida, who had worked in the interstitial lung disease space to try to better use the tools of imaging to understand the vascular component of disease. And we did this, I'm going to show you a bit of this study, to develop an algorithm with the idea is, could we tell from the emergency room who was going to be at risk for the severe vascular conditions that these patients develop. The top figure is a normal patient looking very nice. And then the bottom figure, which I'll explain in the next few slides, show you this blue area, which is actually the small vessels that are being compromised. And I'll talk a little bit about age risk factors for the vascular compromise. So it's a retrospective study. We started out with over 7,000 CT scans, which we randomly assigned. It turned out we used at the end, using 1 out of every 3, 508 patients, 313 were COVID positive and 195 were COVID negative. We went through 10 hospitals. The advantage of the Banner system is that we can pull from a lot of different places. And we looked at scans that had been done within 24 hours of hospital admission. And as I mentioned, we wanted to predict mortality and need for intubation. Our goal was to try to see if we could create a potential tool to use in a prospective study. How does this work? It's really fast. The CT scan is sent in DICOM format into a cloud, where it's then analyzed with these algorithms. It takes less than 20 minutes, and it reports back some values of BVX data and a BV5%, which is really the graded part of the smaller vessels. We use statistical models that were adjusted for covariates that were prognostic for outcomes, and this is the list that I won't go through, but we tried to stratify who we were actually looking at. And this is some of the more picturesque data, as I call it, of what these lungs look like. So on the left is a patient with a BV5% of 21%. So the blue showing you very small vessels being compromised. And the B is the patient with the BV5 of 55%, the non-COVID patient. And it denotes, the red color denotes the larger vessels, 1.5 to 5 meters squared, and the blue is greater than 10 millimeters squared. And what you can see here is that if you looked at a BV5, which is the small vessel, as a categorical less than 25%, in the COVID-19 positive patients, both all of it, mortality, intubation, and mortality or intubation were statistically significant as long as that percentage was less than 25%. Most importantly, if you were COVID-19 negative in the control group, it was not predictive in that group at all. So could it be predictive of outcome? We don't know, because we need to do the prospective study. But what we were able to show in this multivariate model is that a threshold below 25% was associated with an odds ratio of 5.58 for death, 3.2 for intubation, or 2.54 for the composite of death or intubation. And as I mentioned before, the age part was very interesting. So the older you are, if you look at the figure in the bottom of the slide, the red line are the oldest patients, they're 80, right? And the blue line are 50. And what you can see here is that the y-axis shows you the predicted probability of death or intubation, and the x-axis is the BV5%. And you can see that the older you are and the lower your BV5, the worse state you're going to be in. And so this became, this area under these curves where it's able to predict the composite of intubation or death in COVID-19 and be associated with age. And as I mentioned before, it was not predictive of clinical outcomes in patients without COVID-19. So there does seem to be a difference, right, in the COVID-19 vasculature. I think this needs to be tested further, but it's certainly getting us maybe to outside of a blood biomarker, but into an imaging marker, and potentially be able to use the chest X-ray, which we're working on now, because most patients don't get a CT scan, they get a film. Could we use these same kind of algorithms using a chest X-ray? So let me move now to the problem of long haul COVID. We've known about this problem for a while, right? So if we look at saying the first patient in our center was in March, this paper by Carolyn Barber, which hit Scientific American December 29th, 2020, does a pretty good job at discussing all the problems of long haul, neurologic, cardiovascular, renal, pulmonary, and just how the patients don't seem to be able to bounce back. And so if we look at long haul, I'm going to have to show this a couple of times because the screen goes very fast. I'm going to show you a couple of patients that developed long haul disease. It's going to repeat itself as I talk, so this may get a little bit of a nuisance, but this was the best way for me to load it. You can see diffuse findings in this scan, right? The typical findings as you go through it and you look at it over and over again. Really significant ground glass, some of the consolidation that I talked about. And this was a 69-year-old gentleman with diabetes, hyperlipidemia, obesity, with HIV, but undetectable viral load. Came to the emergency room with shortness of breath. He was hypoxic in the 80s on room air. And this was his scan in January of 2021, which is typical COVID. If you look really closely as we go through now, you can see he has bilateral pulmonary emboli, that if I can show you there, which was accounting, we thought, for the severe hypoxemia. 10 weeks post-COVID, though, look at him now. So he still has quite a bit of ground glass opacities. He was put on Eliquis, so he was treated for his PE. He's not quite at the 3-month time point, right, that we're talking about treating him, but he's still very short of breath. So his PE is resolved, but he's still got these ground glass opacities and mosaic attenuation. And the question is, does he have that because he wasn't lavaged? So he didn't have a bronchoalveolar lavage. So we don't know if how much of this is inflammation or how much of this could possibly be ground glass representing vascular compromise. So here he is now at 1 year, and he looks pretty darn good, right? He has no PE, his ground glass has improved, but it literally took a year for this gentleman to get better. This is patient 2. So this is a gentleman who had multivessel coronary artery disease, stats post PCI, had AFib, ischemic cardiomyopathy, diabetes, really significant ground glass, right, throughout both of his lungs. He comes in, he's got fever, chills, shortness of breath. You can see he has a much more disease than the first guy with involvement. He's got pulling down of his fissures as well. His SAT was 92% on 5 liters. This is his scan. Typical COVID findings. He has no pulmonary embolus. He just has severe interstitial findings. Here he is at 8 weeks. He's looking a lot better, but still complaining of dyspnea on exertion, but does not require oxygen. Has a mildly decreased DLCO, not bad, but his pulmonary function is pretty good. But look what's happened in his lower lobes now. As we go through the scan, focus on the bottoms, you can start to see that he's got some chronic changes. So mostly in the lower lungs, but remarkably improved from before. So some of the patients, I show you ones that I think get better, but some look like this, which is how I started this talk, is that they end up with pretty significant really architectural destruction of their lungs, but it's just missing the point of honeycombing. So will they go on, right? Will this go on? We know from the world of interstitial disease that these patients at this stage in the right-hand side here are usually not steroid responsive. So what will we treat them with? Probably they'll end up getting transplanted, because if they look like this, they're not going to be getting better. Who will get like this, I think, is the question. So we've done a little bit of work now with the long-term COVID-19 with Fluida. And what we're starting to see is here's the healthy lung again. And then over on the right is the acute patient that I showed you before. And then this is an example of a long-term patient. We still see the BV5 being altered, but not as severely as in the furthest right-hand side, right, in the acute. But it does seem like they have vessel compromise in their lungs. Clearly, we have to do lots more patients to be able to understand this, but raising the issue of long-term vascular compromise, I think, is very important. So what will be the risk factors for long COVID? Will they be the same as this, I think, very lovely, thorough paper in the New England that talked as a review of mild to moderate COVID? It looks like it could be some of the same things, right? We're certainly identified older age. We've certainly identified underlying lung disease. The last time we heard about cardiovascular disease in these patients, we know that the groups that have chronic kidney disease or diabetes or large BMIs seem to also be at risk. There's a group looking at underlying autoimmune disease, as well as sickle cell, and patients who have been transplanted. So large groups of kidney transplant patients developed COVID, and there will be a lot of information, I think, coming out on the transplant population. What about our cancer patients who develop COVID? How will they fare? And I think we will start to see data coming out that may help us understand, were these also risk factors for COVID-19 long haulers disease? So this is a patient actually with IPF. And the question I have, and I end with this, is will they look like this? Will they end up with these sort of interstitial changes that are chronic with traction bronchiectasis and requiring oxygen, probably with exertion, maybe not at rest? We don't know, but they could ultimately look like this. So I'm hoping that the grass will be greener as we approach spring. This is actually from Boston Common, and I know lots of you have spent time there. These are some of the tulips, and I'm going to end on a bright note and open it up for questions. I think I've left plenty of time.
You have. Thank you very much, Dr. Glassberg. And I've got a very long list of questions. I want to remind everybody in the audience that I'm not the only one who gets to ask questions. I know I see something from Dr. Hammett that just appeared in the chat. Dr. Glassberg, I don't know if that made it to your screen yet, but please do share any questions. There's a lot to unpack, I think, in this presentation, particularly for folks in the primary care setting. There's a lot here, so please bring your questions forward. Otherwise, I'm going to start to get into mine. But I do want to start with Dr. Hammett's question, the first one that came through. Dr. Hammett says, great presentation. You highlighted PE and DVT as possible complications of COVID-19 disease. Given the recent concern about the J&J vaccine, the million-dollar question is, what is known about CVST as a complication of COVID-19 disease? Any insights on this?
So, when that whole thing came about and I tried to look and see who the patients were, who were they that got the problem, I saw that they were young patients, and I've been trying to garner some of the background data, birth control pills, et cetera. I'm not sure, but I think that this PE DVT question in COVID is a big one. Before the whole thing started, we started to look at some of the literature, and the data is sort of all over the place, but certainly I think Bruce, Sean, and I saw that it's certainly a large risk. I am concerned about the vaccine and the thrombotic complications. I was also involved in a stem cell trial, a mesenchymal stem cell trial for COVID, and one of the things that we were concerned about with stem cells is that they can have CD104 on them, which is prothrombotic. And we were starting to see very early on, microthrombotic disease. If you remember, there was a report in Lancet, it was withdrawn, but it doesn't matter because now all the autopsy studies show it. So I don't know about CVST as a complication of COVID-19 disease particularly, but what I can suggest is that I do think that the mechanism that the virus uses to get into the cells is involved high up in the endothelial and coagulation cascade pathway. People have looked at early markers in the coagulation cascade, ADAM-TS13, von Willebrand's, and noted that they're abnormal, but you don't know if that's just because the patient's infected or is that actually something that the bug is doing. And I think that this is an area that will have to be explored.
Thanks, Dr. Glassberg. And you've presented such high quality data in your presentation that I really hate to ask you something based on anecdotal observation, but I'm going to anyway, because it's adjacent to this subject. And discussions that I've had with peers in the EDs and inpatient settings in the Navajo area are that we've observed very larger than we're used to seeing pulmonary emboli, some saddle emboli emerging in the 4 to 8 week recovery period for patients. And I'm curious, if this is something that you and your teams have observed, and if so, B, what would you postulate as the reason for the not delayed presentation, but the delayed emergence of that disease?
So we have seen it. We haven't seen very much of it, right? We've seen more of the large emboli in the acute setting. I would postulate that they have some long-term alteration of the coagulation pathway, that something has been altered long-term, that we need to study them. In the HIV population years ago, there were a series of papers that came out that discussed patients who developed clots on and off different treatments. And they had talked about ADAM-TS13. There's actually a pretty cool paper called Persistent Elevation of ADAM-TS13 in Patients with HIV. I'm wondering if there's some kind of overlap that has to do with a change in the coagulation cascade. Now, why wouldn't that patient have that earlier on? I don't know, except to say that this may be part of what the long-term COVID lack of proper repair process is. I suspect that the patient that's had the clots had hypoxemia somewhere before in the course, that this isn't the first time the patient's becoming hypoxemic. So maybe the patient had some microthrombotic problem, then, because we know our treatments don't necessarily do anything to the clot that's there. If we give them heparin, we know it helps them with new clot, but our Eliquis and all that may not be doing the job. We have seen recurrent emboli as well on anticoagulation. So that's another concern. But I think it's a great question. I don't think it's elementary at all. I think it's really complicated. And I would be interested in the hematologists weighing in on this, because we've tried to get them involved now with what we're doing with the thrombotic indexes, because I think if we could pair some of the markers and see. But so far, if you've looked at fibrinogen, von Willebrand's, all of it, there's nothing, and the D-dimer, as we've seen, there's nothing that helps us predict who's going to go, the road of the thrombotic way.
Definitely not making it easy on us. Thank you. Thanks for weighing in on that. A question from Dr. Irlu brings us to the outpatient setting and for the long-term patients who are recovering. And the question is, which post-acute COVID-19 hypoxic patients with residual infiltrates would benefit from steroids?
So nobody knows this, John. Nobody's done the study, but I think I would treat them as I would any other chronic ground glass. I would make sure there's no other infection going on, right? They as long as they can tolerate bronchoscopy, certainly just making sure they don't have anything else, but we would treat them with a short course of steroids. I think particularly if they do a 6-minute walk and they're desaturating, we need to do further exploration, CT angio, and make sure that what we're seeing isn't related to some vascular problem going on as well. I don't think any harm will be done in giving patients courses of steroids if they have the residual infiltrates. I think the only thing we have to be careful of is making sure we're thinking about what else could it be.
How much prednisone and how long?
We've used Medrol dose packs, and then we've used a tapering prednisone course. So sometimes it's easier with the blister pack to give them that, the Solumedrol in the packs. But we've also done, starting at like 40 milligrams and with a slow taper, particularly in the patients who have underlying like COPD, right? Or an underlying asthmatic. They may benefit from a longer, slower tapering course. But clearly important, I think, to intervene because, common things being common, right? They've got residual inflammation that needs to be addressed. We have not tried any immunosuppressant or steroid sparing drugs. We haven't gone the course of Cellcept or any of that yet.
Thank you.
And for these folks with the infiltrates, that makes me want to ask, are you seeing any increased evidence of superimposed bacterial pneumonia in the longer term course? Obviously, we think about it in the shorter term when someone's acutely sick, but does this parenchymal damage predispose a patient to increased likelihood of a bacterial infection?
We've only seen one with an atypical pneumonia, and we've seen a growing group in Phoenix with cocci. So I think there is an interest from the cocci group to try to see if they had an underlying and then that set them up, that was a risk, or if having COVID gave them the susceptibility to getting cocci, but we see them together. So much so that we've now started to screen for it in all the new patients coming in.
That's very interesting. So we should probably stay tuned to see if that's a protocol that might expand for those who are listening in the Southwest, particularly beyond the Phoenix area. The next question here in the chat is for when managing folks in the clinic who are long-term or long haulers, what are the preferred imaging strategies to assess for, well, I guess, are there preferred imaging studies? And if so, what are they? And then what treatment protocols would you recommend?
So those that have long-term lung disease, in other words, they came into the clinic and already had lung disease, we're seeing them at 3, 6, 9, 12 months now, right? So we do imaging on them, chest x-rays, because we're hopefully trying to get the algorithm so we can use it in the chest x-ray. We do inspiratory and expiratory chest films. I don't think I would scan everybody every 3 months unless their oxygenation is changing, i.e. getting worse. If they're getting better, I don't think you need to do any other imaging. I think you have to recognize that like the cases that I showed you, it's not a fast process, right? You saw 8 weeks, 10 weeks, it takes a little bit, but I think that you don't necessarily have to do repeat imaging. As far as treatments, I think John mentioned we do give them steroids. We are not treating them really with anything else.
Thank you. And the next question is, would you be willing to comment on anecdotal reports of pulmonary improvements in patients with long-term disease post-vaccination?
I don't know. I have been called about this and asked about this, and I haven't seen it. I haven't seen any papers on it. So I think right now we just have to wait and see. I've also heard that those that got the vaccine who then got COVID didn't get as much lung disease, right? So those that had COVID with pulmonary complications got the vaccine, get better. But I've also heard that those that didn't and then get the vaccine and get lung don't get as much disease. So we'll see. I don't know yet.
We will stay tuned. Thank you for that. And I think that we got to Warner Anderson's question with regard to the bacterial pneumonia. Dr. Johnson, one of our colleagues at Fort Defiance, asks, for the respiratory long haulers, what are your triggers for PFTs and a pulmonary or pulmonary referral? You just talked about whether we should be doing serial CTs to track progression of interstitial changes. And finally, any inhaled therapies recommended for long haulers?
So I think some of them do develop hyperreactive airways. So let me answer the last part first, is that would be an indication for bronchodilators. Do I think they have to have PFTs to prove it? It would be nice, but it doesn't have to be. I think if they give you exercise-induced symptoms, they have chronic cough with exertion, for example, I don't think anybody would fault you for trying to use an inhaler. My threshold for sending them to pulmonary is low. I would be happy to see all of them as we try to understand this, but I think that respiratory long haulers who have any element of hypoxemia, and who that means at rest or with exertion. So some of them at rest won't, but then you walk them around and they desaturate. Those people should be referred. And they'll probably end up with a cardiovascular workup too, potentially. But I think I would start by sending them to pulmonary.
And Dr. Strominger asked, like just in time, as you mentioned, walking around the clinic, is that something you would do routinely on a clinic visit for these?
Yes, we walk them around, we mask them up, they actually do, for those that are not remote or have persistent symptoms, we bring them in and we do a walk test. Yes.
Thank you for that. And I also was made aware, and I hope you don't mind me mentioning, Dr. Glassberg, that your former co-presenter from this series from about a year ago, Dr. Michelle Harkins, who's also the chief of pulmonary critical care at University of New Mexico, is on today as well. I'm sure you all communicate regularly about some of this data, and I'm told that Dr. Harkins is willing to be called upon in case there's any additional questions. I mean, but just so our audience knows, between these two critical care leaders, we have about a 700-mile catchment area of folks being taken care of. So we're really fortunate to have both represented. Thanks, Dr. Harkins, for joining today as well. Yeah,
I think, Sean, our plan is to try to get some of this stuff published. So we're working on it. We're working on getting our data. So we have over 2,000 patients in our long haulers clinic now. So I think we will be able to put some data together between Arizona and New Mexico that could be pretty powerful. Because I believe Michelle is on, I think they also have a long-term clinic.
Yeah, I think we're a little behind the realm than you have been, Dr. Glassberg, but we are doing, we're seeing patients 60 days out. We're doing 6-minute walks, chest imaging, PFTs, and referring them to pulmonary rehab, and then following how they do through that. We've also submitted a proposal through the Mountain West Task Consortium to try to really hone in on a few diagnostic studies for the acute patient as well as the follow-up patient.
I guess you point out a very important thing, Michelle, is the pulmonary rehab, which I think follows into how they should be followed from Dr. Johnson, is that I think it is important. We haven't actually got the pulmonary rehab up and running yet at Banner because of the COVID restrictions, but I do believe it's really important that that be built into these long-term clinics because these patients are going to need it. So thank you for that.
I have a question that I think follows off of the discussion about Pneumomediastinum, possibly, but I want to see what you both think. And Dr. Glassberg, another anecdotal observation is incidence of pneumothoraces and spontaneous pneumothoraces in folks who have recovered from COVID, who did not have previous underlying lung disease, COPD, the types of medical conditions we usually think of associated with a spontaneous pneumothorax. Again, is this something that you've observed or been made aware of? And if so, would you postulate the mechanism is parenchymal breakdown secondary to some of the imaging we've seen? Or I'm curious what your thoughts are on that.
Yeah, I don't think we have a good explanation, which is why I put that slide in there about the pneumomediastinum. We all in pulmonary, we like to blame it on barotrauma, right? That's always our thing, right? Michelle's laughing, but that's what we do, right? I mean, the patient's on the vent, the pressures are high, that's what happens. Well, that's not what you see with this disease. So I don't know the mechanism. I have a feeling it has to do with certainly with the pleural damage that we've seen, that we, you don't detect till the patient comes in, right, and has the pneumothorax, but we've seen a lot of it. We have not seen it in the long haulers though, Sean. So we're not seeing it as a long hauler manifestation. Let's ask Michelle if their group, Michelle, have you seen it in the long haulers?
Not per se. We did have a patient that was 29, no medical conditions, had acute illness, and then came to us 6 weeks after his acute illness with right-sided chest pain. Had no other symptoms, and he had a large pneumothorax. He had a lot of cystic changes on his CT scan. So again, I don't know what the mechanism is per se, but cystic formation and maybe they're peripheral and they just ruptured. And it was quite a shock to him because he was actually going to go to work the next day because he felt fine. And this is 6 weeks into it and no other conditions, no smoking, no nothing. So that's the only one that I can really think of acutely right now.
I think with these is that it will be important for us to get these cases into some kind of a consortium where we can look at them and try to better understand it. I mean, we're trying to do some of this with the autopsy material, but truthfully, the autopsy stuff shows you exactly what I showed you, DAD. So it's not going to help us explain this, I don't think, unless we find ones that die with the acute PE and we can see what those lungs look like versus those that have had more ongoing disease. But I can tell you in the 150 we looked at, I didn't see any cystic problem, but we know they do. We've seen it on the CT scans. I think the other thing that's also very interesting for everybody is and certainly from the pulmonary standpoint, and I'm interested in what Michelle might say, is that, these lungs look like they can repair. And they're going pretty far down the road. When I showed you that one film in the beginning, where that's really end stage lung. And those patients can actually get better. It changes the paradigm that the lung doesn't know how to repair. it's telling us that there are things we need to understand about taking the lung down a different pathway, that it's doing itself now with COVID repair. And that's why I think these long, tall clinics that we have to have some kind of cross exchange of information so that we can better understand what happens. Because I think this virus and the generations that come, right, are going to be using some of the same techniques. The thing is, as bad as it can be, and as the death rate can be as high, there's still, the lung can clear it up. So I think we need to understand that process.
Thanks, Dr. Glassberg. And I was reading a question from a colleague with Dr. Harkins' group at UNM, Dr. George, who asks, I've been really curious about this. I've had ECMO patients on for 2+ months whose lungs look as if the transplant was an only option, now home on room air. So
Yep.
I think that speaks to
That's
the point
it.
you were just making.
Yeah. So I think what this is that we don't understand what we're looking at, right? So I think when we look at those scans, we're assuming that it's all within the tissue, and it's and we don't weigh into how much is vascular. I think what the tools that we're trying to develop are telling us that, at least from the data we have, that there's a big vascular story here, and that can repair. When that repairs, the tissue can repair, because you no longer have the oxygen problem that you deal with constantly in the lung. I think that's what, but we have to prove it.
And yep, fingers crossed from Albuquerque and Dr. Harkins, I agree. You showed us some fairly dramatic images, some of which a lot of us are familiar with and have seen many similar in the past year. Do either of you notice any discordance with some of those dramatic radiographic images in the patient's physical exam presentation? For example, somebody who's satting, say, 90% in Phoenix, whose lungs just appear riddled, or is it fairly, what you would expect? What you see at the bedside is what you'd expect to see on the CT?
I think for us, most of it, what we see is what we get, most of it. It's interesting though, Michelle can comment on it. In the early stages, when they come in early and they're very hypoxemic, the scans may not look as bad as they are. But over time, they'll look as bad. In other words, if they stay severely hypoxemic, their lungs aren't going to look good. It's not like the infiltrate's clear and they're still hypoxemic for the most part. If they are, they fall into that, flow sheet of go look for the emboli. Go do those studies, right? Because then it's a mismatch. I don't know, Michelle, what do you think?
I would agree with that. And, as far as their physical exams, I don't hear usually abnormal things. I would say, wow, they're just sitting there and their SATs are 70 and they look fine. And their exam isn't horrible. And and I agree, if their chest x-ray doesn't have bilateral patchy infiltrates, or the CTs, you got to look for something else causing some of that hypoxia or hypoxemia.
Thank you for those responses, and it makes me remember that I think there's a whole, there's a couple of classes of trainees, medical students, nursing students, who are going to do well to recalibrate their impression of the bedside physical exam of someone who's satting 78% on room air, because it certainly looks different than I think what we've come to expect of our COVID patients. Dr. Irlu asked or mentioned that TB incidence nationally dropped in 2020. Not that all cough is COVID, is what they say. Are we missing cocci and TB in COVID's shadow?
Yeah, I think John, I think we're certainly onto the cocci story. We've looked for TB, we've had one case, but once we started seeing the cocci, we started wondering how much we were missing, but doesn't look like we were. But I know this number. I know the TB incidence number. It's also like the influenza story. Like, what else is going on when patients get COVID? But I think it's a really good question. And I think we have to be thinking about it, particularly in those patients that continue with persistent infiltrates.
Thank you.
Thank you. And one last question while we have time, since you're both seeing long haul patients at this point, Dr. Glassberg and Harkins, a question from Sheila Hosner is, other than the lungs, what are the most troublesome symptoms that you've seen in these patients as they've been through the clinic?
So I think that Bruce has drummed in on this. So a lot of it is neuro and sleep disturbances, right? They talk about, Tony Fauci talked about brain fog, right? When he talked, I think they have a lot of that. We're also seeing psychosis. We have a grant to study the acute psychosis in these patients that seems unexplained. We've had a fairly large group of those patients. I don't see that. I think the only systems that don't seem to have long-term effects might be GI. Some of them end up with a tad bit of diarrhea, but that's the end of it. Their kidneys seem to recover. The AKI seems to get better, but I think we're going to find more and more neuro, attention span, sleep disorders, cognitive decline seems to be what we're looking at.
Yeah, there's a really nice review article. I'm thinking of the lead author, Nalbandian, in Nature Medicine,
Yes.
who just in 2021 just goes through all of the specific things. So, but a lot of it is neuro and cognitive issues, psych issues, 20% derm manifestations or hair loss. So it's just, it is really a very nicely written article, and kind of goes through every, complication by organ system. So I would suggest looking that up. I don't have the first name of the author, but Nalbandian is the last name.
Thank you for that reference. That'll give us something to take home, and want to be respectful of everyone's time. I know our lead presenter and then Dr. Harkins, our special guest discussant, both really busy, as we know from their bios, and really are grateful for the time that they've given us. So Dr. Glassberg, thank you so much for really minute for minute, one of the most rich and complete presentations we've had in the past year that we've been doing this. So thank you very much for joining us.
My pleasure.
We'll have the chance to have you join us again for discussion. Thank you, Dr. Harkins, for taking the time to join in and let us cold call on you for some questions. Of course, I think, let's see, Sheila Hausner shared the Nature article that was referenced by Dr. Harkins. So for those who want to cut and paste that now, it's can be found in the chat feature. Well, look, thanks everyone for taking the time out of your busy days to hear about the latest in the post-acute care of COVID-19 patients, specifically focusing on the pulmonary system. We know everyone's very busy, and we appreciate your time today for joining us. We want to thank the Project Echo team for keeping us going a week after, a couple times a month now for over a year, to IHS headquarters and leadership for supporting these sessions every week. Once again, thank you to you all for taking time out of your schedule. We look forward to resuming this in 2 weeks from today. We hope you all can join us again at 12 Mountain Daylight Time. So thanks everyone for joining us. We really appreciate it. Take care.